Hello, thanks for joining me today. My name is Meesha Blair, and we're going to be talking about solitary confinement, especially how it uh, pertains to mental health and some of the repercussions of that practice in the Oregon state prisons, especially. So, as I said, my name is Meesha Blair, and I am a member of NAMI Southern Oregon. If you don't know what NAMI is, that's the National Alliance on Mental Illness. And I serve on the board of directors here, and I'm also the advocacy chair for our advocacy committee. I also teach the family to family class and family and friends class. And most importantly, to this subject and my life, I'm a mother. And that's why I started looking into solitary confinement. Our family, this is our son, Mike. And I like to share some pictures of him because I think it's important that we keep in mind that the people we're talking about that are incarcerated are still people, and they have families and they have histories and dreams. So my son, he had a great childhood and he graduated high school with honors, and he was doing pretty well. We thought he was pretty on track, but the first semester in college, he started having some problems, and we didn't realize that it was a mental illness that he was suffering from. And when he was 19, he had a psychotic break unknown to us and attacked someone and ended up in prison for 10 years. And so this is what I have learned about solitary confinement from watching him being subjected to that treatment, and what it has done to him, as well as a lot of research that I've done in regards to it after having seen my son subjected to it. The first time he was put into solitary confinement was actually when he was arrested. He'd never been arrested before, or been in any kind of trouble. So they automatically put them on suicide watch when they have um, such a high level charge and haven't any experience with jail. And what that entailed was being not only in solitary confinement, which is in our Jackson County jail, is a space about maybe 8 by 10, and by yourself. He was not allowed any phone privileges. He wasn't allowed to have mail or anything to read. He didn't even have his glasses, so he couldn't see. So he was 19 years old, scared to death, no contact with his family, and nothing to read or even know that we weren't abandoning him. So that shocked me. I felt like if he hadn't been suicidal before, that treatment would have made him so. So that's why I started looking into it. So some general definitions about solitary confinement. There's some different terminology that you'll see, and sometimes this can make it hard to track how often it's used because different states will use different terms. And so it's really hard to get some good data on that. It's also called, besides solitary confinement, they'll just call it solitary or isolation. The prisoners refer to it as the whole. Disciplinary segregation units, or DSU, is actually what Oregon uses for their terminology, or just segregation, or seg. Some states have a lot of supermax. You'll hear that term on the news and so forth, and that's what that means. Supermax is solitary confinement constant. So they're never out of solitary confinement. That's what supermax prisons are. And then you'll also hear it referred to as SHU, or secure housing units. And according to the Prison Policy Initiative, which is a website, in 2020, they estimated that 80,000 prisoners in the US were in solitary confinement on any given day. So this is a issue that affects a lot of people. So the United Nations had a special report done in 2011. The Human Rights Council looked into solitary confinement and the practice of it, and they presented a report to the General Assembly about it. And their definition of solitary confinement was physical and social isolation of individuals confined to their cells for 22 to 24 hours a day. And then they further stated that 15 days is what they would call the limit between regular solitary confinement and prolonged solitary confinement, or you'll hear it also referred to as long-term solitary confinement. Because at that point, they found that according to research, that was the point where harmful psychological effects of isolation can become irreversible or permanent. And that is for people that don't already have mental illness when they go into solitary confinement. So I feel like the 15 days is actually very long for folks with mental illness. For my son, he saw negative effects within, 2 to 3 days. And their conclusion was that this practice of solitary confinement causes severe mental and physical pain or suffering. So, used as a punishment or for other reasons, which can even be administrative, it can amount to cruel, inhuman, or degrading treatment and even torture. In addition, it allows certain practices, it's easier to kind of hide them from the public, and they can be left undetected and unchallenged. So if I use the word torture, you know that it's not just my own personal feelings about it, although those that does match, but the UN back in 2011 came up with this definition themselves, and they really urged at that point for all UN nations to stop using solitary confinement, but the United States has not done so. So how about in Oregon? Let's get down a little bit further in, focusing in specifically what we see in Oregon. So in 2015, the Vera Institute for Justice, which is an independent organization, was invited by the governor of Oregon to come in and do a survey and gather data about how solitary confinement was being used in Oregon. And they presented a report called The Safe Alternatives to Segregation. And I have copies of that, but you can also ask Vera for it if you'd like to see the report in its entirety. But some of the highlights of this report were that minorities, women, and inmates with mental health designations were overrepresented in segregation. They took a snapshot on April 1st of 2015. They found that people of color were 26% of the total prison population, but over 34% of the population in DSU. Also, 53% of the total female population was designated as having significant mental health needs. They have a designation where they put MH after the inmate's name. So for instance, an MH3 or MH4 would be considered significant. And they found that 84% of women in SEG had that designation compared to the 53% in the general population. That's a pretty huge difference there. And they found that adults in custody with mental health codes comprised about 51% of the total population. That's any mental health code, so MH1 through MH4, but 61% of the DSU population. So again, more often put into solitary confinement really not surprising if you realize that um, behavior is the reason for being put into disciplinary seg, and behavior is exactly the kind of symptoms that are expressed by mental illness in a lot of cases. So it's not surprising, but it is unacceptable. So what else did they find? They found that it wasn't just violent infractions that were being used for DSU. In fact, the number one infraction that resulted in DSU was disobedience of an order. If someone has a serious mental illness, for instance, they're often incapable of regulating their responses, and for instance, they'll just say what they think without any kind of filter, and obeying an order is very difficult sometimes for folks who are struggling with a behavioral health issue. So the third the the let's see, I'm sorry, over half of the DSU sentences were for nonviolent infractions. And there was also disrespect of officer was another one that was often used for the whole. So I just want to put that out there in order to help overcome some of the misconceptions that solitary confinement is used for the worst of the worst. We have these imaginings that it's the person who's shivving a guard and that's the only person, and really it could be being in the wrong area at the wrong time, or talking back, cussing at an officer, for instance. And that's something that I think we need to keep in mind. And also, people often stay in SEG for long periods of time. The Vera Institute found often up to 6 months, 180 days. And the conditions in DSU entail that extreme isolation and long-term sensory deprivation that the UN mentioned in their definition. So they were 22 to 24 hours alone in their cell without any sort of stimulation or sensory, they had sensory deprivation that entire time. So after the Vera Institute reported and presented their report, I just wanted to mention that there was a memorandum of understanding that was written up between the watchdog organization for Oregon, which is called Disability Rights Oregon, and the Oregon Department of Corrections, or ODOC. And this memorandum agreed to work to phase out and limit the use of segregation, especially for those with disabilities. The result of that was that the ODOC imposed a maximum limit of 30 days in DSU for folks with mental health designations. Now, 30 days compared to 180 days, that's a big improvement. However, 30 days compared to 15 days being torture, not so amazing of a change, in my opinion. Also, they began some programs to create out-of-cell opportunities for inmates that were in DSU. And we'll talk a little bit more about that later, what I've discovered about those programs when I toured one of the facilities. So I'll get to that a little bit later. So let's continue. We're narrowing down even further now to, this is the prison that my son is housed in, Eastern Oregon Correctional Institution. And I think it's good to use EOCI as an example because often the media only uses the Salem facility. And a lot of the improvements are being done in Salem, but are not being done in the other 14 or more prisons across the state. And so I think that if we can do it in Salem, we need to start insisting that it be done in other areas. And even those ones in Salem, I think can be moved along further. They're still using solitary confinement. So it's not like it's completely gone, even in Salem. So when I went to Eastern Oregon, I toured it on behalf of Representative Pam Marsh, and especially looking at the DSU and the behavioral health units. So what I saw when I was there was that the cells are approximately 10 by 10 foot. Some might be as much as 12 foot, but the ones that I saw were about 10 by 10. It's a concrete slab with a mattress is the bed, concrete floors, of course, and then they have the toilet is in there with them, and it's sort of a combined toilet sink. Um, and so when they sleep, they're like right next to the toilet. um, and then they have one tear-proof blanket, which my son says is not enough. It's very cold in there. So there's no desk or chair to write letters on or sit at. There is a small window that's about 12 foot up the wall, and it's frosted quite heavily, so you can tell if it's day or night, and that's it. You're not seeing any clouds or sky or stars at night. And there's a large door, heavy door, that there's a slot in it, and they're fed through that slot. So the tray is just slid in, so they don't even interact with anybody to receive their meals. Um, when they are allowed out of the cell, they have to come up to this door, put their hands through, and they're shackled before the door is opened, and then they're shackled to their ankles, so that they can shuffle off to the shower, say, or if they do decide to go to the outside yard, we'll discuss that more later. Then they're locked into the shower, they put their hands through again and unshackled. So very much, very dehumanizing, and being fed through a slot, being tied up the whole time, has a real feel of being an animal almost. What else? The DSU is an entire building in the EOCI complex. They have about 100 cells in there, 150 maximum capacity. They usually have about 100 inmates in DSU. In fact, inmates are even shipped from other prisons facilities to EOCI to be put into solitary confinement if that facility doesn't have those kind of cells. So there's so now we're going to get into programs a little bit. I mentioned that they were creating programs to allow for out of cell time. There's one classroom at EOCI with 6 desks, and that's for 100 inmates I mentioned. So due to the classroom size, what I was told was the programs are really reserved for those who have long sentences of 90 to 180 days. And there's quite a few people, if they don't have mental health designations, it's not unusual to get 90 to 180 days. So the resulting of that for folks with mental health designations is that they don't actually get access to programs. The folks who have mental health conditions are not getting to be part of the mindfulness practices or the anger management, or those exact programs that would actually help them. They don't. My son didn't even know they existed, so they weren't even offered to him. I told him about them, and he had never heard of it. All of the times that he'd been in. So, and then, as I mentioned, 30 days is the maximum sentence for mental health inmates. However, when I asked them what the average was, they told me 30 days was the maximum. I said, well, what's the typical? And they looked very surprised, like that there would be a difference. And they said 30 days. So it's not just a maximum, it's actually the usual. And there is no minimum time period in between sentences. That is a key detail that a lot of people don't know. So frequently people will go in and then they come out, and since their mental health issue has not necessarily been addressed and it has in fact become worse because of the environment of solitary confinement, surprise, surprise, the behavior hasn't changed. You can't punish mental illness away. So they come out, they still have the same symptoms or maybe worse symptoms, and they end up right back in. So my son had this happen recently. I think it was partly because of the stresses of COVID and not being able to have us visit for over a year. But he had 3 different stints in SEG within 3 months. So out of 120 days, he spent 75 days in the SEG. And just as an aside, it happened to also be all during the holidays. So we didn't get to talk to him on the phone or anything for the holidays, for Christmas or Thanksgiving. So even though this technically meets the specifications of the MOU, that memorandum of understanding I mentioned earlier, does it really meet the intent of the MOU? And I think that's a big thing we need to talk about. And then the usual sentence they said for someone without mental health designation was 90 to 180 days. That's 3 to 6 months in case you need the math. Inmates in the hole have a separate yard that they can access for up to 1 hour a day, but many do not use it. And this is why. They're basically cages outside. This is not the EOCI yard. I wasn't allowed to get pictures of that, but it was the closest that I could find. The EOCI yard actually did not have this space in between the cages. They shared this fence here. So the result was they could heckle each other. And it's very unpleasant. My son says you just sit on the ground, because if you look in here, there's not even a stool. So you sit on the concrete slab and do what? Some people might do some jumping jacks or some push-ups, but that's really it. So the incentive cage had a push-up and a pull-up bar welded inside, and that was considered incentive. Still no chair, mind you. The EOCI DSU yard was actually also not as pleasant as this one, because the cages were surrounded by a large concrete wall that was high enough that it kept you from seeing anything other than the wall. So you didn't get this nice view of the hills back in the background here that you see on this one. And here is just a sample of the processing cages that they sit in while they're waiting to get processed into SEG. These ones are actually a little bigger, I think, than the ones at EOCI. My son says he can't stand up in those, so they're not tall enough for his under 6 foot frame to stand up in. He has to sit there with his legs kind of curled up, and they can stay in those for hours before the paperwork is processed to get him into SEG. So what else? Inmate rumors say that mental health designations are sometimes removed by staff so that inmates can receive a longer sentence. Of course, staff say that that's not true, and understandably. So I have no way of either corroborating or denying that. However, the inmates believe that it's true. So the stress of that is still there. In addition to the physical limitations of segregation, there's also what they call LOP, or loss of privileges, which is all of the privileges that are lost when they get assigned to SEG. And that's loss of phone privileges, not only while they're in solitary, but also after they get out, usually for 2 weeks after they get out. And they have no access to their personal property. So things that they use for controlling anxiety. For instance, my son listens to the radio that helps his anxiety with he has schizoaffective disorder, by the way, which is a combination of schizophrenia and bipolar, and it can be quite distracting and upsetting. And so he listens to the radio a lot, and then also he reads a lot. He doesn't have access to his personal books. It isolates inmates from their support system right when they might be having a manic episode, or some kind of mental health episode. And in fact, there isn't even a clock. So they just get completely isolated from what's happening in the world outside. As I mentioned, that can continue for 2 to 4 weeks after release from SEG. But also, they can have fines of, I don't know, but my son had one that was, I believe, $1,500 the first time. When you're not making money, that's kind of a big deal. When he did get a job, it garnished his wages, which, a job inside, you're lucky if you make like $30 a month. So if they take $5 to $10 of that a month, and then they also garnish any money that the family sends in for them to use for things like hygiene and healthcare items of their personal items. They lose any job that they had, and then they lose levels. This is very important repercussion of solitary confinement because it's very long term. Um, so rehab programs, they have lots of very cool sounding, interesting rehab programs like dog training, electrical engineering, so forth. But all of these rehab programs you would think would be encouraged for everyone to participate, but they're actually put forth as incentive programs. And it takes 12 to 18 months of good behavior before they can even apply for these programs. And when they get solitary confinement, that's considered poor conduct. So they lose their good behavior record and they start back at zero anytime they get put into segregation. And there's also different things like different jobs that they can't do if they've lost their levels because they're restricted access, and a lot of other things that go on like this. There's even certain things in the canteen they can't buy unless they have a certain level. So it's very restricting and creates a lot of despair. So I'm going to talk a little bit about the results of segregation to folks that have severe mental illness while they're still in prison. And the extreme sensory deprivation, as you can probably imagine, increases the symptoms and actually adds further illnesses in. My son, for instance, now not only has schizoaffective disorder as a diagnosis, but he also has anxiety disorder and PTSD. I'm going to read you a letter in just a moment from my son, a little excerpt. But there's even less ability to interact with others. My son says he can no longer read body language, so he has a really hard time interpreting when people are talking to him what they mean, and it makes it even easier to assume that they're insulting him or get offended, and that triggers his illness. There's higher levels of completed death by suicide while in SEG than there is when they're in general population. And there's also increased other self-harming behavior like cutting. Isolation is well documented as a dangerous behavior that leads to relapse and psychosis. If you have a loved one with a serious mental illness, you know that when they start isolating, that's a red flag. So to force them to isolate I sort of liken it to having somebody with lung cancer and forcing them to smoke, 2 packs a day. It's not only not treatment, it's anti-treatment, if you will. And then the despair that comes up for folks, and the loneliness. My son feels like no matter what he does, he can't win. And so it's understandable that rage and other PTSD symptoms are very common for folks who are in segregation, or who have been in it for a long time. And then, as I mentioned, they're denied programs like college courses and skills activities. And that is an important piece for a lot of people to survive their sentence. It gives them something to focus on to get through, especially in Oregon where we have so many long mandatory minimum sentences due to Measure 11. There's a lot of people that are in there for a very long time, and without something to give you a sense of purpose or something to focus on, it just is so long, and so difficult. And they can even lose their housing. So if my son goes to segregation, he doesn't know if he's going to get back into the mental health unit or if he's going to end up on a completely different unit when he gets out. And that causes him a lot of stress. And then, of course, those who don't have a pre-existing mental health condition might develop them, from being 90 to 180 days in these conditions. I'm going to read a little excerpt from a couple of my son's letters here. And I typed it out here for you, but these are letters that he wrote me while he was in segregation. And in March of 2017, he said, "I miss you a lot. I'm crying because I miss you so much. I miss talking to you on the phone and seeing you on video visits. It is very lonely in here. I'm having a lot of hallucinations in here, mostly spiders and big centipedes. Yuck, they're there 1 second, gone another. It's because I have so little stimulus to combat this." And then a couple years later, he writes about, quote, "new development in my nightmare problems. I talk in my sleep. Also, I have waking nightmares where it feels like someone is grabbing me and I can't move or speak. It's terrifying. Also, I just had a really bad nightmare. In it, I hurt someone and I woke myself up because I was saying over and over, 'I'm sorry, I'm sorry.' I haven't had a good night's sleep in weeks. I wake up every couple hours. My dreams are vivid and cruel. My body is stiff and sore. My eyes are gritty and filled with flashbacks. I miss you. I think of you constantly. I even thought of you in my dream last night. I thought, my mom is going to be so sad. I'm tired of being crazy. It sucks. I miss you so much. It hurts." So, one thing I'd like to point out before I move on is that my son says that one of the issues with solitary confinement and hallucinations is that when he's not in seg, he can gauge some of the hallucinations, whether they're real or not, by the reactions of people around him. So if there's a loud noise but nobody else responds, then he knows, oh, that's probably a hallucination. Or if somebody's whispering and he looks around and nobody else is hearing it. So without that ability to compare against his surroundings, those hallucinations just take over. And it's very sad. It makes me very worried for him. So, I've also done some research about the results of solitary confinement after someone's released. Obviously, my son's still incarcerated, so I haven't had direct exposure to this, but I wanted to know, what can we expect when he gets out? So, research shows that long periods of solitary confinement can make it even more difficult to adapt when they come back to the outside world, which we know is already quite difficult for them. Um, there's a higher recidivism because they have fewer skills. They've been denied rehab programs and jobs inside, so they're just used to being idle, forced idleness. They don't know how to um, live in this high energy, fast paced world when they get back out. Um, Also, they've done some studies now that have found that there's actually a higher risk of premature death after release for people who have been in segregation compared to those who were not. And then community safety is impacted by releasing inmates that have more problems than they did when they went in. So we've made them worse, we've made them more sick, um, and knowingly so, because the research is out there. This is not rocket science that nobody understands. And then we release them and we're surprised that they're more sick. It doesn't make any sense. This is a little graph that I got off of the internet. I think I put on here from the Prison Policy Initiative's website. They did this research about solitary confinement and how it increases the risk of premature death after release. So you can see there that it's quite a bit higher on this right. And that's any solitary confinement at all, let alone 180 days at a time. Okay, so what do we do instead? And that's the big question that we get a lot when we talk to folks in the system, the Department of Corrections. They say that first of all, they don't know what else to do instead. So if you look at some other countries, Norway is a good example. Although it's hard to compare Norway to the US because they're so different. They have a completely different paradigm where they're working together to create skills for success, as opposed to it being about punishing. And, you know, we talk about not being a punitive society for prison. However, I think that it really is still set up that way. For instance, when I was speaking to one of the upper staff at Eoci Yard, and I was talking about solitary confinement and how you can't really incentivize behavior for someone with mental illness, and that you can't just give an incentive for them to change by putting them in segregation. And he said, quote, "It's not about incentive, it's punishment." So that really shows that we still are very much a punitive paradigm in our prisons, and whereas Norway is not. And if you look at the rates of incarceration, the rates of recidivism compared to ours, nothing alike. So really what they're doing is working much better. Oregon did discontinue solitary confinement for its juvenile facilities just a couple of years ago. And I think having some information about how that went, what alternatives they put in, that could really help with the larger adult system, to give them some ideas of how it works. Although they don't believe that they're the same types of inmates. So again, it's a cultural issue. New York State recently passed legislation that they called HALT solitary, and that creates rehabilitation units instead of segregation, where it is meant to be a rehabilitative and therapeutic unit, specifically to provide programs, therapy, and support to address underlying needs and reasons for their behavior. And they have at least 6 hours a day of programming plus an hour of recreation. So I think that this could even be more of a dorm style than, which is more what general population is at EOCI, and not have to be shackled all the time, and be able to interact with others. The New York didn't specify this, but I think keeping their contact with their support systems, their outside support systems, while they're trying to figure out what's going on with them is very important. Another argument that we get a lot is that the DOC needs to focus on safety of their staff. And absolutely, of course, everybody needs to be kept safe. But there's this misconception that solitary confinement somehow keeps staff more safe. But actually, what they found in Mississippi, of all places, was that when they discontinued solitary confinement due to a lawsuit that they had to discontinue solitary confinement, and they actually found that both inmate on inmate and inmate on officer violence decreased after that. So there is no research that I have been able to find anywhere that shows that solitary confinement increases safety of anyone. Um, and in fact, the opposite has been shown to be true, because there's so much discontent and rage and PTSD that's created from solitary confinement. It actually makes the environment less safe. Some of the key elements to consider when we're looking at alternatives for Oregon is to, of course, remove the inhumane physical isolation as often as possible and as quickly as possible. If there is an extreme situation, and I'm aware of this, having a son with a mental illness myself, that sometimes the symptoms and the episode can get very extreme, and as we mentioned, people need to be kept safe. However, I've I've never heard of anybody having, well, maybe there is somebody, I shouldn't say never, but for my son, definitely, he doesn't need 30 days to get calmed down. Um, a day maybe, and then he's back to kind of being able to be compliant and get a grip on himself. Um, so if it's used at all, I think having a system where it's signed off on and it's reviewed quickly, so that they don't just sit in that situation. And addressing the underlying issues that are causing the behavior. Um, if it's a mental illness, then instead of making that mental illness worse, what needs to happen to make it better? Are they not being compliant with their meds? You know, require that they are. Uh, they require a lot of other things, or provide therapy and other treatment options, and work on helping them to get better coping mechanisms. And then encourage activities that will not only assist in their recovery, but also will help them succeed when they get out. Any kind of job uh, gives them a little bit of feeling of pride and self-worth, which is very hard to come by inside, and gives them that work ethic that will help them when they get released. And if they're allowed to keep their jobs, or to be able to return to them after they get out of that rehabilitation unit, um, that would really help. And then, of course, encourage rehab programs as much as possible and remove the barriers to them, for people with disabilities, including mental illness. This is a legal issue, in my opinion. My son's mental illness is a disability. Schizoaffective disorder is a very serious disability, and he's not being allowed to participate in rehab programs because of the behaviors that are brought on by that disability. It's a direct link, and it needs to be addressed. and then allow them to maintain their support systems, as I mentioned before. There are some cultural changes that need to happen, I think, in order for those key issues to be addressed at all. First of all, acknowledging the trauma-informed, evidence-based research that's out there instead of saying it's the way we do things. I can't tell you how many times every time my son gets put into seg, I call them up and complain because I know that it's going to make his mental illness worse. And I always get told, well, it's our policy. And so I say, rewrite some policies. Additional training for guards and staff on gender and racial issues, since those issues did come up in the Vera report, showing that they were getting punished more often. And then gathering more safety data so that facilities can understand, staff can understand that these changes will actually make things better for them, not worse. And I think not only do we need to have trauma-informed practices for inmates, but we need to have it for staff as well. We can't expect staff to respond in a calm and compassionate way if they're suffering from PTSD that's not being helped out and receiving treatment for. So I think we need to expand that culturally and not just specifically for inmates. And we need to create transparency. I think that's self-explanatory. So the costs, that's always a discussion, unfortunately, but it does come up. So how do we pay for these alternatives? Well, we're already paying for DSU, and those units are the most expensive to run of any of the housing units. They have a higher guard to inmate ratio. It takes more of their time to do everything. They have to feed each inmate individually. A guard has to deliver the food. A guard has to get them out to take them to the shower and then take them back. It's just very labor intensive. And so it's actually quite high. I don't know because I don't have access to the cost of DSU versus a regular general population. And I'm not sure, we'd have to get that from the DOC. I don't know. I don't know if they would be willing to share that with us. And then, we've talked about some of the other repercussions. How do we even measure the cost of a higher recidivism? We know that it's very expensive because it keeps people in prison, which is very expensive. And there's so many ripples out from that. Mental health treatment, the higher mental health treatment, that's further down a little bit, but we have so many costs that are involved already. And how do we put into monetary value the value of a human life that's lost to suicide or overdose, from that graph that we saw earlier of people dying, higher rates of death after release. So what is the value of that? And then Medicaid and mental health services after release for those whose illnesses were worsened, the costs that we put into trying to help people find jobs that they now have no skills for, and how do we measure the effects of these practices on minorities and women? There's a lot of talk right now about improving relations and how we treat minorities and women. How do we even begin to understand the depth of the harm that we're creating by putting more minorities and women in solitary confinement? I just don't even know how. So basically the question comes down to, how can we afford not to make significant change? Norway spends so much less money on incarceration than we do, with our 2 million people in prison, in jail at any given time. It's inconceivable. So in conclusion, solitary confinement is torture. The UN said it. Everything that I've seen holds up that belief. It affects thousands of people just in Oregon every year, and there are cost-effective, evidence-based alternatives that have better outcomes. I polled when I did this before in a larger group. I polled people after listening to this information and to find out how they felt about it. And, maybe think about that yourselves a little bit. Um, on a poll of 1 to 5, 1 is it doesn't really relate to me, so I'm not bothered by it, to 5, I'm just enraged. 100% of the people that listened to this before were fives. And I'm grateful for that. I think we need to share this information as much as possible because I think most people, if they knew what was happening, would be very upset by it. Uh, so we are getting ready to work on making some changes in Oregon. If you'd like to be part of that solution, NAMI Oregon is helping out with that. So you can contact us through the NAMI Oregon website. We need people from all areas of the state. Now that we have Zoom, I mean, it's changed things completely. So we can all come together, all our separate little groups, people that are concerned, we can come together, band together, and work on this together, and create a campaign of largely of education. Like I said, I think if people know about this, then they'll want changes. So will you help? And we need to do better, and we can do better. So thank you so much for your time on this. I hope I've answered some questions. There are still a lot of questions out there just because of a lack of transparency and an inability to get to those to that data. But I really appreciate your taking the time to listen, and I hope that NAMI Oregon will hear from you and that you will join us in this effort. So thank you very much, and have a great rest of your day.